Welcome back. This audio will focus on chapters 1 and 2 in the text with an introduction to speech sound disorders, providing you with some basic terminology that we're going to use throughout the semester, and summing up with some normal aspects of articulation and how we produce sounds, or how children acquire the skill of producing sounds. So, as we start with our introduction to the study of speech sound disorders, chapter 1 really focuses on the idea that clinical phonology or speech sound disorders or articulation versus phonological disorders, the terminology has really changed throughout the years. When I was a student, we really differentiated between articulation disorders and phonological disorders. And that really came with the idea that articulation disorders were more motor-based, and that it was really a disorder of the actual production of the individual sounds, whereas phonology really came from a linguistic background where linguists believed that articulation disorders, or speech sound disorders, I should say, were not only a result of motor production difficulties, but that lack of understanding or knowledge of the appropriate use of sounds in children. So children have to understand that s is used differently than z, and we put a back sound in a certain word rather than a front sound for a specific reason, and there's a difference in the meaning that comes of that. So that phonology idea really separated the field from articulation versus phonological disorders. Well, that was pretty much the leading idea or thought process that was prevalent until, I would say, even the early part of this century, where articulation referred to production-based speech sound disorders, and phonological disorders were really referring to speech sound errors that are rule-based. So there are rules behind the way we produce a group of sounds. But in reality, it's really very difficult to differentiate between the two, and we see that as clinicians. A lot of times we will work just on articulation, but is a phonological theory really going to help you get the child to produce a specific sound more efficiently? And maybe. So that's why I think the field has really come to more of an understanding that speech sound disorders are speech sound disorders, and they all are phonologically based in a sense, and it's really hard to tease out whether articulation or phonological matters are behind it. So in this textbook, you will often find phonology, articulation, speech sound disorders kind of used interchangeably. Although there is a general differentiation between articulation and phonology, and that really holds more true when we talk about assessment and treatment. But in terms of theoretical backgrounds, the book really does not differentiate between the two, articulation and phonology. Another kind of background that we need to set up is the difference between delay versus deviant. Okay? And we've seen this in our language courses, that there are some children that present with a language delay, where you will see that given them time and development, they will kind of come to the same level of their peers, versus children who have a language disorder, where they really may not ever meet the same level of their peers. With intervention, we can compensate for some of those disorders, but typically there is still a disorder seen. So we see similar things in terms of speech delays versus speech deviance. Okay? And this really can help us determine if therapy is warranted, if an assessment is even warranted. So we talk about children that are maybe 3 years old, okay? And we often have parents say, but they're producing their S with a frontal lisp, their tongue is being protruded out of their mouth, or they're talking like Elmer Fudd, and their R sounds are produced like W sounds. Well, is that a delay? Is that typical? Or is that a deviant production? We know, based on normal acquisition, when certain sounds are expected to come in for children. And there's a range. A lot of the normal acquisition charts that we look at, where we see S doesn't come until later, or CH is a later developing sound, whereas P and M are earlier developing sounds, those are really based on studies that looked at groups of children, and we've determined that a certain percentage of those children have acquired those sounds. So say 75% of children acquire the P sound by the age of 2-5. So therefore a child at 3-5 that's not producing the P sound is delayed in a sense. But again, this is really based on groups of children that have developed the sound by a certain age. So a delay is really referring to a sound error that is normal, but it's typically not seen in a child their age. So lisps are often considered delays, frontal lisps, I should say. Whereas deviants are sound disorders that we never want to see in children, that even children at younger ages should not be producing. An example of that would be actually a lateral lisp. So if a child says shummer instead of summer, or thummer instead of summer. So the first one I said was shummer, where I had a lateral lisp for the word summer. That is a deviant speech production, okay? We never want to see that lateralization of the S sound. We never want air to really escape over the lateral margins of the tongue when producing the fricative S, okay, that sibilant sound, a sibilant sound. So that's a deviant production, whereas a child that's producing F instead of S, so you can't really hear me probably, but I'm producing more of a frontal production where my tongue is protruding out beyond the upper and lower teeth, instead of S, where my tongue is staying behind my teeth. Okay, that's typically thought of as a delay, okay? And often younger kids will produce this, but by the age of 6, even 7, we really don't want to see that anymore. The child should have demonstrated appropriate production by that age, and therefore it's an error that we want to correct. So this comes into play. So do we work on a frontal lisp with a 3-year-old? Do we work on a lateral lisp with a 3-year-old? Our assessment and intervention strategies, especially in a school setting, or if we're looking at being reimbursed from insurance companies, okay? Sure, can we work on all of those skills at every age? Can a child at 3-year-old possibly benefit from therapy if they have a frontal lisp? Maybe, if they're intellectually ready and their attention span is appropriate and they can learn from your therapy, then why not work on that skill with them? Well, it's not appropriate because it's not developmentally appropriate. You might do it as an individual service or a private service, but you're not going to get reimbursed through an insurance company, or the parents, I should say, are not going to get reimbursed through an insurance company, and their therapy is not going to be provided by a school district or a township or what am I trying to say, Board of Ed or Board of Health or things such as that. Those governing bodies are not going to provide therapy for some delays that are just not appropriate at that time. So again, difference between delay and deviant, which is going to affect our assessment and our intervention. Okay, we want to really consider that. Another thing that we want to really understand is that oftentimes, for the most part, most children with sound disorders or speech disorders, there really is no known cause. Yes, we do have children with speech sound disorders that are related to middle ear infections or hearing loss or other kind of genetic factors that may come with types of syndromes and such So we know children with Down syndrome will also demonstrate speech sound disorders. But a lot of times a child may not have a hearing loss, or a child may not have a cleft palate, for instance, or may not have a syndrome. And so their speech disorder, their articulation disorder, or the phonological disorder really has no known cause, and that's kind of hard for some parents to understand. But what we do say is, for articulation disorders in particular, it's a muscle pattern. Children are producing that error pattern. Their muscles are doing something in error for a significant amount of time by the time they're 6 years old, when we might start services. And they've developed this habit. It's like working out. Okay, you're working out your muscles. Your tongue is a muscle. Your lips have muscles that make them move in certain ways, right? So just as you go to the gym and you work a muscle for a certain period of time, your body gets used to that routine, gets used to that movement, okay? And there's a habit that's formed. So too, when you're producing, I keep using S, but when you're producing, let's say, TH, like an F, okay? When you're producing that pattern over and over again, there's a habit that has formed. So a lot of times speech therapy is not necessarily about getting the child to being able to produce the sound appropriately, but rather to get them to produce that sound appropriately more consistently, because they have a habit of doing it the other way. All right? And so consistency and changing that habit, or that muscle production, or that muscle movement, or that muscle pattern is what we're really trying to do. And a lot of times we say, well, seeing a speech therapist 1 time a week or 2 times a week for 30 minutes, is that really going to help? Well, it's not going to hurt, right? We need to teach them the correct pattern, and we need to monitor their production. But practice, home practice, parent involvement is key, okay? If we don't have that continued practice day after day after day, we're not necessarily going to be able to change these muscle patterns that have developed, either from a delay or from a deviant pattern, okay? And again, we don't necessarily know the cause, so we have to just keep working on the symptomology that is being presented to us. So that's a little bit about the basics behind what we're doing. Again, as in everything that we do as clinicians, we're always striving towards evidence-based practice. We don't just work on a sound and do what we think is appropriate. We don't just play games, which, although some people believe that's what we do, that's not what we do. We have evidence. We know what research and best practice tells us, and we know how to work on skills based on previously supported evidence, okay? So evidence-based practice, so best external evidence, that research that tells us what to do. Clinical practice, what clinicians have been doing for a long time, okay? So we know that that informs our plan, and what the clients really need from us, okay? That's going to drive what techniques we use. We're not going to provide therapy to a person who has a dialectical difference, or a child with a dialectical difference, or a child who may have a first language that is affecting their production of English sounds. If that child and that child's family does not think that the services are warranted, right? We have to consider culture, we have to consider family. However, if we're in an academic setting, working in a school, and that child's production is affecting their ability to learn, is affecting their phoneme to grapheme discrimination skills, and thus is going to have an impact on their literacy development, then that's a question, that's a conversation that we must have. But we always want to remember culture, okay? We always want to remember family values, and we always want to remember evidence-based practice, okay? In terms of what we do with our clients and how we do that, and what treatment is best for these people, for these children, okay? All right, so we're going to move on to Chapter 2, Normal Aspects of Articulation. A lot of this is background knowledge that you probably have had in other courses, okay? Knowledge that you should have developed at this point, but we're going to reinforce it, and we may highlight it in a different way as it affects our clinical competence skills in working with children with speech sound disorders. I know last semester we spoke about the difference between phonemes and allophones and phonetics and phonemics and phonology, so you guys should be well aware of that structural part of language, okay? What we want to kind of highlight here to differentiate stuff that we've learned already, on page 7, you see that we use what's called enclosed virgules, those slashes, that front slash, when we're writing out phonetic transcriptions, okay? We use this in terms of assessment, so we write down how a child is producing a specific word or sound or sentence, and we use phonetics. We use IPA, okay? That's important because we want to know exactly how the child is producing the sound. Because a child that says movie theater instead of movie theater, if we write theater, no one will know what we're talking about if you show it to somebody. So we use the phonetic transcription. It's the language, it's the alphabet that we use. And by providing those brackets, those slashes, they help us to know what to read, what's coming as. Okay? So again, as I said in one of my previous audios, I will expect you guys to start practicing your transcribing skills. We will have some practice sessions in class when I see you guys in Manhattan. So start working on those skills again. Okay? Vowels are tricky, but remember, you're writing down what the child is producing, not what you think it should be. Okay? So you're writing down what the child is producing. And that is how you're going to focus your transcription skills. Okay? As we go through the text, we go through how the speech mechanism, how the respiratory system, how the articulation system are going to affect the production of certain sounds, what body parts are involved. So if you look on page 11, we really start getting into the organs of speech production and what we use to produce our target sounds. The respiratory system includes the lungs, the airway, the ribs, the diaphragm, and all those structures that provide us with the air supply to produce sound, the source of speech, right? Okay, if we don't have that air that is produced in the respiratory system that goes through our larynx, okay, where we start the vibration happening, we're not able to articulate properly. We're not really going to focus on respiration and voicing at this part. We're going to jump past the larynx and really start with the velopharynx, because here's where we look at articulation anatomy, okay? So the velum, or the soft palate, is that structure in the posterior portion of the oral cavity that really allows us to differentiate between the nasal cavity and the oral cavity, okay, that velopharyngeal port, okay. Air passes through the oral cavity for oral sounds, and the nasal cavity is blocked off by the velum raising, okay. Whereas nasal cavity, the velum lowers so that air can pass, nasal sounds, the velum lowers so that air can pass through the nasal cavity to produce nasal sounds. If we have a dysfunction in this velopharyngeal porting, or this system that separates these two ports or channels, the nasal cavity and the oral cavity, we may have a disorder. A lot of times we consider those disorders more resonance disorders, but we can look at it from an articulation standpoint as well. Okay, the next articulator that we will really focus on is the tongue. Okay, the tongue is extremely important in most of the sounds that we produce, okay? And it's a complex of muscles, as the book says, actually. There are muscles that go in an up-down position, top to bottom, muscles that are more intrinsic, and they move in and out, so they can shape the tongue in all different positions, okay? And you guys probably went through all the muscles of the tongue in your anatomy class, And if not, then go through that material. I'm sure you have a text that can help you out a little bit more if you need some further information. But it is the main articulator in the oral cavity, okay? Those different shapes allow us to produce different sounds. Movement of the tongue in various ways allow us to produce different tongues. When we talk about certain sounds that we produce, it depends on what portion of the tongue is articulating another articulator, in a sense. So there's the tip of the tongue, which is the most anterior portion, okay? Right behind or posterior to the tip of the tongue is the blade of the tongue, and then more posterior to that is the dorsum, and then finally the most posterior portion of the tongue that connects at the floor of the mouth is the root of the tongue, okay? There's more movement in the more anterior portions of the tongue, so the tongue tip and the blade, and as opposed to the more posterior portions of the tongue. Okay, excuse me. But those are the main areas, and not forgetting the body of the tongue. That's that main portion of the tongue that kind of underlies everything else. Okay, you can see that nicely in the figure 2-3 on page 12 of your textbook. Okay, and then we have a couple of more articulators, the lips. Okay, the lips help us produce rounded sounds and spread sounds. We'll use the tip of the tongue to produce sounds against our lip in different ways. And furthermore, the jaw. Okay, the jaw really helps us with opening and closing the mouth in various shapes and ways. Okay, really at this point in producing sounds, we really want that up-down motion of the jaw. We don't want a lateral movement of the jaw, which we often see with children with speech sound disorders. They kind of shift the jaw or slide the jaw in a lateral direction, and therefore some of the sounds they make are impacted by that lateral shift. We really need to ground the jaw and to really provide a nice foundation for production of other or movement of other articulators in order to produce sounds in an appropriate way. The jaw really comes into play when you're working with preschool-age children a lot, because many of the sound disorders that they present with are the result of not having a nice, firm foundation using the jaw appropriately. That being said, excuse me, we want the jaw to move separately from the other articulators. You want your tongue to not have to move where the jaw moves. You want your tongue to be able to move independently of the jaw. Okay, we call it tongue-jaw dissociation. Okay, and that's extremely important because in order to produce an alveolar sound, we don't want your jaw jutting forward and moving up to get the tongue to move. You want your jaw to remain in that foundation-like position to provide support for your tongue to be able to move independently. Okay? I wish you could see what I'm doing with my mouth right now, but I'll show you some demonstrations as we go through of children. I have videos of children that are producing sounds in different ways that is both appropriate and inappropriate. Okay? What I will say about the respiratory system, though, it really is something that actually combines the respiratory system and the articulatory system. When we produce continuant sound versus stop sounds, right? We need to either let air continue to flow, or we need to stop the air at certain points. So continuant sounds, we have a nice flow of air that's continuing, and there's no articulator in the oral cavity or nasal cavity that's really blocking that sound or stopping that sound. Whereas stop sounds, you have that flow of air until it reaches a certain point in the oral cavity or nasal cavity where the air is stopped. Okay? So you kind of have more pulses of air in that respect. Okay? But that takes us through pretty much the main anatomical structures of articulation. Okay? But know that all of these are happening in such a small area, and there's so much neural control over these small areas. There's a large part of the brain, if you guys remember back to the homunculus, I'm sure you've learned about that. There's a lot of cortex that is devoted to the muscles in the mouth, and there's not a lot of room, there's not a lot of surface area of those muscles, so there's a lot of fine control, neural control, that really affects how these muscles move, and one little movement out of whack or one movement in the wrong direction will really have effect on the sound production, okay, and therefore we may have a speech sound disorder, or a misarticulation, I should say. Okay, as we move forward, vowels, the book provides you with a nice description of how vowels are produced, and I was talking about this in one of my previous audios. You really want to understand the difference between high vowels and low vowels, okay? High vowels in which the tongue is high in the oral cavity, low vowels in which the tongue is low in the oral cavity, versus front vowels in which the tongue is more in an anterior position, versus back vowels in which the tongue is in more of a posterior position. Okay? Rounded versus spread or tense vowels, lax versus tense vowels. Okay, where the tongue does not have a lot of tone in it. For lax vowels, and there is a lot of tone in the tongue for tense vowels. So if you look at the quadrilateral on page 16, the lower portion of figure 2, 8, okay, you see that we have our front vowels from high to low. We have E, I, A, A. Okay, E, I, A, A. I'm sorry, I just messed up my I have a child that I'm working on this with, and I'll show you videos of him, but he continuously has difficulty with that sound. So we work on where the tongue needs to go and where the mouth needs to go, high or lower in space, okay? So we can produce that range of front vowels from E to I to A to E to A. Okay? And then we have our back vowels. Again, I'll go from high to low, but we have oo, o, ah. Okay? And finally, the mid vowels, or those central neutral vowels, the sound. Okay? Right there in the middle. Okay, but the vowel quadrilateral is important to know in terms of assessment as well as in terms of intervention, because a child may have difficulty with high vowels, and then you'll know that it's the E, it's the I, it's the it's the sound that they may have difficulty with. Or if a child has difficulty with a group of sounds, you might realize that, oh, it seems like they have a problem with low vowels, so it's the A and the sound, or sound. I should say, if they have a trouble with those lower vowels. And then you can see that it's a group of sounds that you really need to work on that. For instance. Okay? So the next, like I said, the next couple of pages really go in depth in terms of how vowels are produced. Something that I really want to point out that is going to help you throughout the semester in terms of vowels as well as in terms of consonants, and actually will help you on your speech sound disorder project, is the description of distinctive features that is provided on page 19. So what is a distinctive feature? You guys have done work with this, I am sure. You may not specifically know what it is, though. So it's kind of a method of describing sounds that was really started with Chomsky, actually. Chomsky and Hale, I want to say. Chomsky and Hale's distinctive features. Way back in the middle of the 1900s. Sounds so old when I say things like that. But I want to say like the 1960s. So distinctive features is really a plus or minus. Has it or does not have it is a what we call a binary system. So it's either one or the other. Okay? Way of looking at sounds, okay? Way of looking at aspects of those sounds. So, for example, one aspect might be voicing, okay? Does the sound have voicing? Is it voiced? So we'd say positive with a plus sign. Yes, it's voiced. If it's voiced, it cannot be unvoiced. It cannot be devoiced. Okay? Therefore, it would be, and if it were unvoiced, it would be minus voicing. So plus voicing or minus voicing. Can't be both at the same time. That's illegal. So in terms of vowel sounds, you're going to have a nice chart on page 20 of your text, 2-1, which really goes through each vowel sound at the top. So e, and so on, okay? And then you see the distinctive feature chart below. So is the sound sonorant? Remember we talked about sonorant on our vocabulary list in the previous audio? Well, sonorant are those open sounds, okay? And all vowels are sonorant, okay? So therefore you see a plus across that entire row. Vocalic. Is it produced with voicing? Yes. All vowels have vibration of the vocal cords, okay? Therefore you see a plus across that entire row. They're all vowels. That's what a vowel is. They're vocalic. Consonantal, is there consonant? No, vowels are not consonants, so you see minus across that entire row. The differences that we often see are in these cavity features in terms of vowels. Okay, are they high vowels? Well, we know that E and I are high vowels, therefore we see a plus there. E, A, and so on until we get to are not. Until we get to U, I should say, are not high vowels, so there's a minus sign there. When we get to U and we do have pluses in those columns for U and for high vowels. Aw and are not high vowels, they're low vowels, so there's a minus sign there. And you could do the same thing with low and back and rounded and nasal. Okay? No vowel is supposed to be produced with nasal through the nasal cavity. They're oral sounds. Therefore, you see a minus across the row for nasal. And then finally, tense vowels, whether the tongue is tense, or lax vowels, whether the tongue is lax, is the final row. So that's your manner. Okay? We could do the same thing with distinctive features with consonants. So consonants, as opposed to vowels, would obviously have a plus sign across the consonantal row, right? Vocalic different. We could have stops versus fricatives and things such as that, plus or minus. Are they sibilant? Are they sonorant? And things such as that. So this distinctive feature way of describing sounds is a binary system, whether they're presenting with that category or characteristic or not with that category or characteristic. Okay? We also use that plus minus in terms of consonants, and you'll see that on page 23 of the text, table 2.2, that final column, voicing, okay, goes through all the consonants, whether they're voiced or unvoiced, okay? So we could look at place, manner, and voicing in this entire table. We have our bilabial sounds produced with the lips. P, B, M, right? So P and B and M are all bilabial, but they're not all nasal sounds, are they? P would be minus if we looked at it in terms of nasal. B would be minus if we looked at it in terms of nasal. M would be plus if we looked at it in terms of nasal. Okay, and there's our distinctive feature for those sounds. Although they're all produced in the same place, they're not produced in terms of the same manner. Voicing. For P, there is no voicing happening. It's a devoiced sound, so it's a minus in terms of voicing. B and M are both positive, plus in terms of voicing. Okay, so you see that there. Then we go on to our labial velar sounds. Labial in the sense that the lips are used, so there's rounding. Velar in the sense that there's some opening there in terms of the velum. So those sounds are our glides. That's our manner. They're glides. Okay, there's movement in terms of the oral cavity. And sometimes we call them semi-vowels because of the reduced amount of constriction and the voicing that's happening with w in terms of which, okay? That's positive in terms of voicing. We don't necessarily use the which anymore. That's kind of old school English. Most people will say which and which, the WH which and the WITCH which, the same way. So we really do not differentiate those today. But if you went to England, you would probably differentiate them a little bit more. And therefore, one is plus voicing, one is minus voicing. Labial dental, we use the lower lip for the labial portion, and dental, we use the upper teeth, front teeth, to produce these sounds, f and v, okay? And those are fricatives in terms of manner. There's that frication happening, some air passing through. F, again, is minus in terms of voicing, and v is plus in terms of voicing. So you see the distinctive feature way of classifying it there. Lingual dental, we usually use the term intradental more often, but you can say lingual dental. Okay, this is our TH, both the voiced and unvoiced production of it. Lingua alveolar, okay, usually we'll just classify these as alveolar sounds. We kind of understand that the tongue is necessary to produce these sounds, and all of these, we kind of, not all of these, but the alveolar sounds, the palatal sounds, the dental sounds, and the alveolar sounds, where lingua precedes it in this chart, we kind of just assume that the tongue is working, so we kind of shortcut it to alveolar sounds. Our alveolar sounds, we have a lot of different manners of production here. We have stops, we have fricatives, we have nasals, we have laterals, and we have flaps in terms of alveolar sounds. Z versus D. Z, D, and th are all different matters of articulation, but they're all voiced, right? Whereas T and D are both stops. So manner is the same, but T is not voiced and D is voiced. Okay? Interesting, though, there's an error. Yes, there is an error. If you look on this table, in the second column, phonetic symbol and keyword, lingual alveolar, you have T per 2, but then below that, the stop do should just be a D, okay? It should just be a D. They copied the voiced TH, actually. So next to do, in between the two slashes, it should be a D, so you could correct that in your book. Okay? I just noticed that. Alright, so lingua alveolar sounds. Then we have our palatal sounds, okay, in which much more of the hard palate is used to produce them. Sh, zh, ch, okay? There's much more connection or approximation between the tongue and the palate for these sounds, okay? Finally, you have our your velar sounds. Your velar sounds, which are your back sounds, your k and your g and your ng. Okay, some are nasal, some are not, some are stops, actually, and some are voiced and some are devoiced. And then finally you have your glottal sounds, which are your h and your stops. And those are your glottal sounds that don't even reach past the glottis in terms of constriction. So articulation-wise, there's no constriction beyond the glottis. Okay? So the text goes into more detail about all of those. Table 2-3 classifies them as opposed to place of articulation. It goes through manner of articulation first and then breaks it down that way. Just different ways of breaking down the different sounds. It's really important that you know, if I say, what is a bilabial stop sound that is voiced? You should be able to tell me what that is. You should be able to tell me what a nasal velar sound is. You should be able to tell me what a alveolar fricative that is voiceless. Okay? You should be able to tell me all of those. Okay? And the charts on these 2 pages really help you with that. Okay? Excuse me. Okay, and that really takes us through the majority of this chapter, where each sound is described in terms of constriction and where the articulators are placed, okay? Excuse me. And then finally, on page 35, you actually have your distinctive feature chart for most of the sounds. You have p, b, m, t, d, n, s, l, f, and k. And you could fill in the rest. So, for example, you have the cognates p and b right there. You have t and d right there. You don't have the z, but if you look at the s column and made your own column next to that for z, you can pretty much figure it out. So s is plus for consonant, so is z. S is minus for vocalic, minus for sonorant, and minus for interrupted. So would z be, because it is a consonant, there's constriction, so it's not sonorant, and it's a continuous sound, so it's not interrupted. Stridency. S does have stridency, so does z. So it would be plus there. High, low, back. We're really not going to focus on that. That's minus for all of those. Same thing would be the same for, z. And then anterior. Is it an interior sound? Yes, it's produced in the anterior portion of the oral cavity. So plus for a s, plus for a z. Coronal, produced in that coronal plane. Same thing for s as z. Rounded. It is not rounded, s, and neither is z. Distributed. It is not distributed, s, and it is not distributed, z. Okay? Lateral. S is not a lateral sound. Neither is z. Nasal. S is not a nasal sound, neither is Z. Voiced. S is not a voice sound, but Z is. So you'd see the difference here. There'd be positive or a plus sign in your distinctive feature column for Z. Okay? I hope you don't have questions for that. You could really come up with your own distinctive feature chart for every sound that we produce, vowels and consonants, using these categories. And this is what you're going to be expected to do for your target sound in your paper. Okay? You're going to describe it. You're not necessarily just going to provide a list of these categories. I say explain them. So explain what it means to be strident. Explain what it means to be lateral. Okay? You're not just going to list the pluses or minuses for the sound you have. You're going to explain them. Okay? Excuse me. And this section, the chapter really goes through each category, describes it, and then identifies what sounds are produced with those appropriate distinctive features. Okay? All right. As we continue on, we get a little bit more into resonance and prosody in terms of rate and stress and things such as that. We're not really going to focus on that in terms of our discussion. But what I will bring your attention to is page 42 of the text. And we're actually at 42 minutes of our discussion right now. So 42 of the text talks about co-articulation. You guys are familiar with what co-articulation is, I am sure. It's really when the sounds are put together, how they affect the other sounds that surround them. Right? So we talk about all these distinctive features. We talk about how to produce each individual phoneme, but when in reality we speak, we do not produce them isolated. We produce them in conjunction with other sounds that are around it. So the word cat is not k-at, it's cat. And the production of the k affects the way you produce your a. And the production of your a affects the way you produce your k. And same thing with production of a affecting your t, and the production of t affecting your a. Co-articulation, right? Each of those individual sounds lose their individual identity, okay? And thus we have each sound really influencing the other sounds, okay? There's a little description about Easter eggs and how that identifies co-articulation, but what it really tells us is that although we know how to produce individual sounds, in reality, when we're in the clinical setting, when we're assessing and intervening, we cannot just focus on the individual characteristics of the sounds. We have to really consider how that sound is going to be produced in conjunction with everything around it, with the influences around it. So there's a nice example on page 43 where you look at the word asked versus the word answered. Okay? The word asked begins with your a sound followed by your oral s, right? The word answered begins with the ah sound, followed by your nasal okay? So if we were to look at the production of ah in asked versus the production of ah in answered, acoustically, it would look different because we're producing them differently. Because in answered, we're taking the nasality of the okay, and we're already anticipating that nasality when we produce the ah. So that ah is produced with some nasality. Whereas in asked, there's no nasality on the second consonant, that's right? So the ah is produced on its own with influence from the s and not influence from the as an answer. Okay? So that's just kind of a nice description of how co-articulation will affect the production of each individual sound. Well, why does it matter? How is this going to help us clinically? And the main thing that I want to get across is co-articulation actually is something you must consider as a clinician, because certain vowel contexts, certain consonant contexts, what vowels before the sound you're working on, what vowels be after the sound you're working on, in syllables and in words, will either help or hinder the child's ability to produce that sound appropriately. So you may find out that ka, production of a ka sound, will be enhanced if your next vowel in the words that you're using as your therapy target is a back sound, since ka is a back sound. So the word cup might be more easily allowing the child to produce the ka sound rather than the word keep, okay, because the E is a front sound. So you might want to assess or probe the child in all of those vowel contexts, okay? You might give him some words and see which vowel context is going to enhance their production of the target that you're working on, which is ka, right? And I'm exasperating the just so you can hear it over the audio. So cut and cup and cuddle are going to be the words that I'm going to use in therapy in the beginning of our therapy sessions so that I can get him to produce the ka more consistently. Eventually, he's going to be producing it more consistently. Then I could throw in some front vowels like keep and kit and kid and words with front vowels so that he obviously is going to have that practice. But I'm going to start out with the productions that are going to be more easily facilitating the production of the target that I'm working on. And that is how co-articulation could enhance my therapy session. Okay? It could also hinder my therapy session, right? So if I were to use all front vowels, then I may not see my child progressing. And my knowledge of this is going to help me in therapy. A clinician that doesn't have this knowledge is just going to throw out any word with any vowel following the target sound or preceding the target sound, and really their data is going to be it's going to be swayed, right? So you may have some that the child is getting and some that the child isn't getting, but if you really analyze it, they're really producing the sound correctly in the context where co-articulation is enhancing the production of the target sound rather than co-articulation inhibiting the production of the target sound. And that's what I really want to make sure that you guys understand in terms of co-articulation and speech production. Okay. So those are really the areas that I really want to highlight in terms of Chapter 2. So we've gone through Chapter 1, Chapter 2, okay? I'm going to do a separate audio for Chapter 3. I want to keep the files a little bit shorter so that you can listen to them on different times if you like and focus on them. So done with Chapter 1, done with Chapter 2. Next audio is going to focus on Chapter 3. Thanks for listening.